and ketamine in pediatric patients as procedure sedation. Even you can ask other questions also with sir. And this one is the base paper presentation in Isapan Maha Nagpur chapter. Sir is an associate professor at Dr. PDMC, PDMMC Amravati. Sir is a one of the most wanted, I can say, is faculty for national and state conferences nowadays, and he's having various publications on segmental spinal, as we everybody knows on that, and Dexmedetomidine. So I will be very much thank you, sir. You came again on our platform second time, and this one is also good topic. Last time you presented segmental spinal, and I personally tell you that I did now 200 cases till date, segmental spinal, with your discussion with your case meet now, and our colleagues also learning these things, and maybe in your future we can do workshop on that. And second thing, I'm really looking forward on this also, dexmedetomidine and ketamine prospectus that we will use as a private forum point of view regularly henceforth. So thank you, sir. Once again, you are coming on our platform. Please share your screens.
Thanks, Sachin, for the kind introduction. I'm very much thankful to ISN Nanded for inviting me again on this platform. It's really a pleasure to be there with ISN Nanded. They are doing so much activities. Without wasting much time, I'll start with my presentation. So my topic for today's presentation, are you able to see my screen?
Yes, sir. Yes, sir. It's
yes.
Very clear.
Am I audible? Audible?
Yes, sir. Very, very clear.
Okay. My topic for today's presentation is dexmedetomidine and ketamine in pediatric patients as procedural sedation. So initially, we will look a brief review about some aspects of pediatric procedural sedation, and then about the individual drugs, dexmedetomidine and ketamine in pediatric patients, and then the magical combination of Dexket. So initially, a brief review about some aspects of pediatric procedural sedation. The pediatric procedural sedation has expanded in volume and demand over the past decade. Everything from the name to the drugs, practitioners, monitoring guidelines, and billing codes has evolved. In contrast, very few new sedatives are developed, and many are not approved for children. The current sedation guidelines are often contradictory and vary both between and within specialty groups. In context to this procedural sedation analgesia, children are not just small adults, more likely to have airway obstruction during sedation due to larger tongue, epiglottis, and occiput. Children desaturate more quickly after apnea than even moderately ill adults. They require more frequent sedation dosing, and sedation levels are difficult to assess. They more likely and quickly can go to deeper levels of sedation. And the drug doses calculation be based on precise weight measurements and not on parents' estimate. This is a common mistake people make. According to American College of Emergency Physicians, the definition of procedural sedation analgesia is a technique of administering sedatives or disedative agents with or without analgesics to induce a state that allows the patient to tolerate unpleasant procedures while maintaining cardiorespiratory function. What are the goals and aims of pediatric PSA? Henceforth, we will be calling it as a PSA. To guard the patient's safety and welfare, minimize physical discomfort and pain, control the anxiety, minimize psychological trauma, and maximize the potential for amnesia. Control behavior and or movements to allow safe completion of procedure. Return the patient to a state in which safe discharge from medical supervision is possible. Intent is to achieve these goals while assuring that the patient is able to independently maintain oxygenation, airway control, and cardiorespiratory functions. These are few of the previously used terms, like moderate sedation, also popularly known as conscious sedation, is a drug-induced deprivation of consciousness in which patient responds purposefully. Deep sedation is patient cannot be easily aroused, but respond purposefully after repeated or painful stimulation. And the third is a special kind of dissociative sedation, typical of ketamine, is a trance-like cataleptic state characterized by profound analgesia and amnesia with retention of protective airway reflexes, spontaneous respiration, and cardiovascular stability. To assess the depth or the quality of sedation, there are various scales which have been developed over time. One of them is University of Michigan Sedation Scale. This is an observational tool that scores the patient's responsiveness to stimuli for assessment of depth of sedation in children aged 6 months to 12 years. This is a 5-point scale. I'll not go into detail of this. The conscious sedation, which was previously used term, is equivalent or less than University of Michigan Sedation Scale 2. These are some other parameters like behavioral response, airways, spontaneous ventilation, cardiovascular function during minimal, moderate, deep sedation, and general anesthesia. All these parameters are usually well maintained in moderate sedation, minimal and moderate sedation. Ramsay sedation score is amongst the oldest and the most widely used of the scales in both adults and children. This is a 6-point scale. Pediatric sedation state scale. This is a new 6-point pediatric sedation state scale intended to analyze the quality rather than the depth of sedation. The University of Michigan sedation scale used to analyze the depth of sedation. Here it is the quality rather than the depth. And in this, the state 2 is supposed to be an ideal state for procedural sedation analgesia. After sedation discharge, readiness can be evaluated by alternate recovery score. Alternate recovery score takes into account the activity, respiration, circulation, consciousness, and color. There are some points for each of them, and the total score must be more than 8 at the conclusion of monitoring. What are the prerequisites for PSA? Emergency resuscitation equipments appropriate for pediatric patients should be immediately available. And for this, SOAP-ME is a useful mnemonic where the S stands for suction catheters apparatus, O for oxygen supply and delivery equipments, A for airway equipments, P for positive pressure delivery systems, M for various types of monitorings, E for emergency cart with alternative airways. Pre-procedure fasting guidelines according to ASA: clear liquid 2 hours, breast milk 4 hours, infant formula, non-human milk, and light meal up to 6 hours. Now, procedures requiring sedation, as you all know, there are non-invasive or invasive procedures. Amongst the non-invasive, MRI, CT, other imaging studies, radiation therapy, electroencephalography. In invasive and painful procedures, various types of biopsies, then lumbar puncture, endoscopies, various types of scopies, thoracocentesis, paracentesis, burn dressing, wound debridement, fracture reduction, placement and change of central lines, ultrasound guided aspirations, etc. etc. The choice of sedative agents, the targeted depth of sedation, and the agents used largely depend upon the anticipated degree of pain, allowable amount of motion during the procedure, and following patient factors: whether the patient has any comorbidities, fasting status of the kid, age and developmental level of the kid, ability to cooperate, degree of anxiety, and any prior problems with specific medications. Commonly used drugs for pediatric procedural sedation analgesia. Remifentanil is not freely available, so I have not included that. Commonly used ones are midazolam, propofol, etomidate, ketamine, and a new all-in-one drug, dexmedetomidine. Then there are various permutation combinations which can be used, like one is remifentanil with propofol, the other one is ketofol, that is ketamine plus propofol, and the most important and the magical one, that is dexmedetomidine and ketamine, which is being used very widely nowadays. It can be used intravenously, intramuscularly, buccal route, or intranasally. Now coming to dexmedetomidine in pediatrics. Though off-label, dexmed has a firm position in pediatric anesthesiologist armamentarium. Its respiratory sparing effect and bioavailability by various routes are some of the valued features. It's a highly selective alpha-2 agonist, provides sedation that mimics natural sleep, anxiolysis, sympatholysis, and analgesic sparing effects without respiratory depression. Off-label use is generally acceptable if there is no suitable alternative available or used in accordance with the current medical opinion. Recently, the potential organ protective effects with preserving neurocognitive function has put it in the forefront of clinical and bench research. Pharmacokinetics and dynamics in children, they change markedly from neonate to infant to adult. Highly lipophilic drug, high volume of distribution, predominantly bound to plasma proteins, crosses blood-brain barrier. It has a rapid distribution phase of 6 minutes. Elimination half-life is around 1.8 to 2 hours. It's broken down by hepatic enzymes to the inactive metabolites. Clearance in neonates, which is around 42.4% of adult values, it reaches to 84.4% by 1 year of age. So the clearance in neonates and infants is reduced owing to immaturity of elimination pathways. So it should be used with caution in neonates, especially in the first 2 weeks of life. Hemodynamics after dexmedetomidine in children, it has a dose-dependent effect on mean arterial pressure and heart rate. Median effective dose intravenously over 5 seconds without significant hemodynamic compromise was found to be 0.49 micrograms per kg in healthy children. Transient dose-dependent hypertension can occur more frequently with large boluses and more likely in infants than in older children. Bradycardia up to 30% from baseline should be expected. Use of anticholinergics to treat bradycardia should be with caution, as transient hypertension can occur after the use of anticholinergics. So bradycardia needs treatment only when concomitant vital signs are abnormal. It usually resolves after reducing or stopping dexmed. Features of dexmed sedation: child sedated but arousable, alert, and respond without uncomfortable delirium-like state. It usually resembles natural sleep. May return to sedation again. No clouding of consciousness like drugs acting on GABA systems like midazolam or propofol. Dexmed sedation lacks amnestic properties. This is the only drawback dexmedetomidine has. Analgesic opioid sparing effect lasts quite longer. Even it can last up to 24 hours after the use of dexmed. There are some special indications for dexmed, even at higher than recommended doses, that is around 3 micrograms per kg per hour. Dexmed maintains the airway patency and tone in obstructive sleep apnea kids. So it is an ideal choice for drug-induced sleep endoscopy and dynamic airway imaging. For EEG in patients with autism and neurobehavioral disorders, it is useful due to its non-EEG and seizure altering effects. Recent literature supports intranasal dexmed 2.64 micrograms per kg for sedation for pulmonary function tests in children aged 1 to 3 years. Recent interest in using dexmed to provide sedation, anxiolysis, analgesia for pediatric patients with severe symptoms near the end of life. It has a special interest nowadays in palliative care. Recently, the Italian drug agency has passed a landmark decision approving dexmed via intranasal or intravenous route for the palliative care of children outside the ICU setting, that is in the hospital or at home, and unresponsive to conventional therapy. Intranasal dexmed for sedating child with epidermolysis bullosa and one with refractory dystonia without side effects was found to be very effective and without tachyphylaxis when used at home for up to 3 months. Some relative contraindications or precautions. Rapid bolus of dexmed along with high concentrations of volatiles should be used with very cautiously. There are some other conditions like cardiac conduction abnormalities, septic shock, concurrent treatment with digoxin, beta-adrenergic blockers, calcium channel blockers, MAO inhibitors, or other agents that predispose to bradycardia and hypotension, where it should be used with great caution. And also in hepatic diseases, where the elimination half-life can be prolonged even up to 7 hours. Caution in infants and neonates. Caution should be exercised when dexmed sedation is used in infants and neonates receiving epidural analgesia without support from external warming devices. Infants depend more on non-shivering thermogenesis than on shivering and vasoconstriction. So dexmed interferes with non-shivering thermogenesis, and it has a potential for hypothermia as a result of inhibition of lipolysis. Longer elimination half-life and clearance in premature. So lower doses of dexmed are usually recommended. Routes of administration and doses. Dexmed is used by almost all possible routes except for rectal route. So Dexmed has been described by intravenous, intramuscular, intranasal, oral, buccal, and recently by subcutaneous route of administration. Intravenously, the loading dose of 0.5 to 1 mcg per kg, followed by 0.2 to 0.7 mcg per kg per hour. Intramuscularly, it can be 1 to 4 micrograms per kg, and intranasally, it can be from 1 to 3 micrograms per kg. Bioavailability by oral route is very poor, so oral route is usually not recommended. And buccal route of administration can be very challenging in pediatric patients. So the most preferred route after intravenous is an intranasal route, which needs special mention. So intranasal is the most used extravascular route of Dexmedetomidine administration in children. Bioavailability by nasal is around 40.7%, and buccal is more. They differ quite markedly, but still the buccal Dexmed has not been found to be superior to intranasal Dexmed. This is the most convenient, minimally invasive, and Dexmed can be delivered by droplet method or by mucosal atomizer devices. There is no nasal irritation like intranasal midazolam. Additional benefits are reduced post-op nausea, vomiting, and need for rescue analgesics. Time to peak effect with 2 to 3 micrograms per kg in children aged 0 to 11 years was found to be 45 minutes. There are some disadvantages of intranasal Dexmed. When used alone, the sedative effects are concentration dependent. At a plasma concentration between 0.2 to 0.3 nanograms per ml, patient may be in arousable sedation. And plasma concentration above 1.9 nanograms per ml, patient will be in deep sedation and difficult to arouse. Heart rate is also dose dependent, and so the increase in the dose may lead to decrease in the heart rate. Dexmed induced sleep is like natural sleep. Even with high doses of Dexmed, child may get awakened by external stimuli, leading to failure of sedation. For more effectiveness, better to combine with another drug rather than increasing the dose of Dexmed. This is mucosal atomizer devices, which can be used for intranasal delivery. Draw back the plunger to fill the syringe with proper medicine volume, connect atomizer, inject half the drug into the nostril, inject the remainder into the other nostril. This was a study comparing the buccal and nasal dexmedetomidine pre-medication for pediatric patients, and the conclusion was intranasal dexmedetomidine 1 micrograms per kg is more effective than buccal administration for pre-medication in children. Now coming to the another drug, that is ketamine. You all are familiar with this drug using from ages together. So ketamine is a phencyclidine derivative, non-competitive NMDA and glutamate receptor antagonist. This is a anesthetic with sedative, analgesic, and amnestic properties. Dose dependent effects. It is anxiolysis and analgesia at low doses and providing dissociative sedation, amnesia, and analgesia at higher doses. There has been given a level A recommendation by American College of Emergency Physicians policy statements for both safety and efficacy in providing PSA for children in emergency departments. Subsalient features of ketamine dissociative state: child passes into trance-like state, eyes may remain open. There is normal or slightly increased muscle tone, analgesia is excellent, amnesia is total, airway reflexes are usually maintained. Slight increase in blood pressure and heart rate, nystagmus and lacrimation is typical of ketamine. Indication, contraindications, we all know indications: providing sedation, analgesia for moderate to severe short painful procedures like suturing, fracture reductions, incident drainage, removal of foreign bodies, etc. Relative contraindications: children below 3 months of age, active pulmonary infections, including upper respiratory infection, cardiovascular diseases where increases in the heart rate and workload is not desirable, suspected or increased intracranial pressure, glaucoma or acute globe injuries, thyrotoxicosis, porphyria, psychosis, etc. Routes of administration, most commonly given by either intravenous or intramuscular route. Intravenously, it is 1 to 2 milligram per kg over 1 minute. Repeat 0.5 milligrams per kg every 10 minutes as needed. Onset is within 1 to 2 minutes and duration is 15 to 30 minutes. Intramuscularly, it can be from 3 to 5 milligrams per kg, even more. Onset 5 to 10 minutes, duration 30 to 60 minutes. There are possibly higher adverse respiratory events, higher rates of emesis, longer recovery period with intramuscular ketamine. So whenever possible, intravenous route is preferable. Side effects, there can be random purposeless movements, muscle twitching, rash and vocalizations, tachycardia, hypertension. Hypersalivation can be there, transient laryngosspasm can occur, apnea and respiratory depression is also transient. MS is more common with intramuscular use and children over 8 years of age. Unpleasant emergent phenomena can occur more common beyond mid-adolescence, and it can be decreased by positive psychology prior to administration. You can conceal the child and take him to his dreams, so that can reduce the side effects, unpleasant emergent phenomena. Recovery agitation is common in 1.4% of the kids. Now coming to the my most favored and magical combination of dexmedetomidine and ketamine. Literature search was conducted by PubMed, Relax, and Embase to identify 21 articles from 2015 to 19 that address the use of dexmedetomidine and ketamine together during anesthetic procedures in population between birth to 18 years old. And the conclusion is the literature is favorable to the use of DexKet for invasive, non-invasive procedures inside and outside the operating room, presenting an attractive profile for pediatric patients. The combination of dexmedetomidine and ketamine makes pharmacological sense. They balance the hemodynamic and adverse effects of each other. Dexmed prevents the tachycardia, hypertension, salivation, and emergence from ketamine, and ketamine prevents the bradycardia and hypertension caused by dexmed. Ketamine also speeds the onset of sedation and eliminates the slow onset of dexmed. The most effective regime is bolus dose of 0.5 to 1 mcg per kg of dexmed plus 1 to 2 mg per kg of ketamine mixed together, diluted, and given slowly over a minute to initiate target sedation. The maintenance can be 0.5 micrograms per kg of dexmed plus 1 mg per kg of ketamine as needed, short boluses, or it can be used as an infusion. Co-administration can be intramuscular, buccal, but intranasal is the most preferred route when intravenous is not feasible or desired. Lack of recovery-related agitation is very significant with the use of DexKet. Potential utility of this combo for procedural sedation in kids with compromised cardiovascular and respiratory functions. In pediatric MRI, combo of intramuscular dexmed and ketamine was superior to either drug given individually. Useful combination for securing difficult airway of infants, toddlers, and developmentally challenged children while maintaining the spontaneous respiration. In drug-induced sleep endoscopy for OSA in children, it is found to have more success with less incidence of O2 saturation as compared to when midazolam or propofol is used. It is more useful for such procedures. Its successful use has been reported for children undergoing cardiac catheterizations, upper GI scopies, extracorporeal shock wave lithotripsy, muscle biopsies, mediastinal mass excision, etc., etc. This is a chart to show the heart rate changes with Dex and DexKet administration. With the Dex alone, there can be initial bradycardia, but with DexKet, you can see in the pink box, it is usually well maintained. So is the mean arterial pressure with DexKet. With Dex alone, there can be a biphasic response, initial hypertension followed by hypertension. But with DexKet in proper combination, you can have a maintained mean arterial pressure. These are a few of the studies which I have included in my presentations over the last 10 years. This was during 2010, dexmedetomidine and ketamine for sedation during spinal anesthesia in children by Joseph Tobias. And they found that the combination of ketamine and dexmedetomidine provides effective sedation during spinal anesthesia in infants and children with limited effects on cardiovascular and ventilative function. This was again by Joseph Tobias in 2012, an effective alternative for procedural sedation. And the conclusion was the trial is favorable regarding the utility of combination for procedural sedation. This was a study about a combination of dexmedetomidine ketamine for upper GI scopies in children, a preliminary report. It was in 2013. And the results of this case series show that this drug combination not only promises to be clinically effective, but also safe for upper gastrointestinal endoscopies in children. This was in Pediatric Anesthesia Journal, comparison of combination of dexmedetomidine-ketamine to propofol or propofol sevoflurane for drug-induced sleep endoscopy in children. And their conclusions was the dose regime of propofol used alone or in combination with sevoflurane appear to be associated with more oxygen desaturations and a lower rate of successful completion than the combination of dexmedetomidine and ketamine, especially during DICE in children with OSA. This was in Journal of Anesthesia and Clinical Care. A new approach to procedural sedation in children. The intramuscular use of dexmedetomidine and ketamine. This was used for transhepatic central venous access in a 13-year-old with acute ventriculitis. They used it successfully by intramuscular route. This was in Pediatric Anesthesia Journal. Analysis of 17,948 pediatric patients undergoing procedural sedation with a combination of intranasal dexmedetomidine and ketamine. And the procedural sedation using this combination by intranasal route is associated with acceptable effectiveness with very low incidence of adverse events. This was again a study comparing midazolam ketamine versus dexmedetomidine-ketamine for anesthesia of pediatric patients undergoing cardiac catheterization. This was in 2019. And the conclusion was DexKet combination was superior to midazolam ketamine combination because of less intraoperative ketamine consumptions required for adequate intraoperative sedation and shorter recovery time. This was in Brazilian Journal of Anesthesiology in 2020. Propofol ketamine versus dexmedetomidine-ketamine for sedation during upper GI-scopies. And the conclusion was the propofol ketamine combination was associated with shorter recovery time, but patients used to have more desaturations with propofol ketamine combinations, while the DexKet combination showed less need for additional doses. This was in American Journal of Emergency Medicine. Dexmedetomidine combination with ketamine for pediatric procedural sedation for premedication. DexKet for pediatric sedation results in better sedation outcomes than dexmedetomidine or ketamine alone by shortening onset of sedation and recovery while maintaining hemodynamic and respiratory stability with low incidence of adverse events. This is in 2021, the intranasal dexmedetomidine plus ketamine for procedural sedation in children, adaptive randomized controlled non-inferiority multi-center trial, KETODEX. It's a statistical analysis plan. This is ongoing trial using different dose combinations of individual drugs to evaluate the non-inferiority of intranasal DexKet or intravenous DexKet. This is still an ongoing trial. Now I'll show some short pictures or videos. Most of my previous videos got deleted, so these are few of them which are left with me. I'll just show it. This is a circumcision 1-year-old, 8 kg under DexKet and caudal with ETCO2 monitoring. I don't monitor this regularly, but just for presentation, and using a 18 gauge intracath to monitor the ETCO2 in this patient. This is 4 years old for intraocular lens implant. I've done more than 30-40 cases of intraocular lens implant under this combination. The surgeon is very fast, does it within 10-15 minutes. I usually give DexKet and then the surgeon himself gives the block, perivalvular block, and that's enough. These are two endoscopic foreign body removal, one in 2.5 years old child. This was a battery cell, 3 days old, lying in the lower esophagus. And the other is a 5 rupee coin, which was there in the esophagus. This is a 3 years old child. Must have done more than 25-30 these kind of foreign bodies in kids with just DexKet and 10% LS spray. This is 3.5 years for lacrimal probing under DexKet. For lacrimal probing, if the surgeon wants to do syringes, then it has to be done very gradually, putting a catheter tip in the oropharynx, not stimulating the oropharynx, but just keep the tip in the oropharynx and gentle suctioning. Ask the surgeon to do it gradually. Otherwise, the patient may cough during syringing. This is 2.5 years, 12 kg congenital hernia, Dexket plus spinal. This is congenital hernia again, 1.5 years, 9 kg, Dexket plus caudal with NIBP, TCO2 and SpO2 monitoring. This is just for presentation purpose, different types of monitoring. This was a 1-year-old, 14 kg. Hemoglobin was 5 grams, OSA with difficult venous access and airway, large abscess on the medial side of the thigh. Venous access was taken on the left foot and just Dexket was given for abscess drainage. This is 2.5 years, 9 kg for systolithotomy and prepusal dilatation for phimosis, Dexket and spinal. Not even oxygen is required with Dexket alone. If you don't use propofol, then there is no airway collapse or desaturation. This is 2 months old kit for tenotomy. Most of the times I do tenotomy with Dexket and caudal block, but this was done with just Dexket and local infiltration at the incision site. This was sort of Ludwig's in 5 months old, 6.5 kg neck abscess, Dexket alone. Generally avoid propofol in such kind of cases. Large abscess. This was a 2 years old, 9 kg lacerated on soft palate. Suturing was done under Dexket with local infiltration. This is just 20 days old neonate with extra digits on both hands. Weighing 3.5 kg, Dexket was given and local infiltration. This is 6 years old, fracture both bone forearm, K-wire fixation under interscalene block after giving Dexket. This is lasso tendon repair in a slightly bigger children, 14 years old, 30 kg. Lasso tendon repair for claw hand due to leprosy, Dexket and local analgesia. This is a collage of different difficult airway procedures in kids which I have done. And that's all. Thank you very much for patient listening. These are a few of the references. And if there are any questions, I'll be very happy to answer. I'll stop sharing my screen.
Thank you, sir.
Was it clear all through?
Yes, sir. It's what?
Okay.
Very much clear. For participant, any question, kindly put in question and answer box. Sir, you are giving Dexket IV. I want to know what is time schedule for that giving Dex and ketamine IV?
I usually mix them together. You have to mix them together for proper effect, because Dexmed has a slower onset and ketamine usually speeds the slow onset of Dexmed. So better combine them together. I usually combine 0.5 mcg per kg of Dexmed and 1 milligram per kg of ketamine in a single syringe, 5 ml syringe. Make it to around 5 ml and then give it slowly around or half or 1 minute and titrate to effect once the child is sedated.
In a syringe of 5 ml or 2 ml syringe, you mix
5 ml syringe. I use 5 ml.
You mix it both things.
Take both the things in one syringe and then dilute it again.
Okay.
5 ml.
Okay.
And titrate the dose. Okay. Usually 3 to 4 ml of this combination is sufficient to sedate the child.
Yes, yes, yes.
For more painful procedures, you may need some propofol or some local anesthesia. But
Okay.
for just sedation before your blocks or spinal or renal, it is sufficient.
So you mix both things in
Yes.
5 ml and 1 to 2 minutes you will give with children's. Is it?
Pardon?
It will be given duration of 1 to 2 minutes. You mentioned.
Within 1 minute. Actually, I am now used to it, so I give it within half a minute or according to situation. Nothing usually happens. There can be
So
little bit of
last time, so many, I think that Naik madam's case it was that cleft palate and surgery, and she was reluctant about Dexmed in situation. You were there, and she told about 15 to 20 minutes duration for Dexmed, actually. But you
yeah,
are mentioning,
I have
yeah,
used Dexcat in cleft lip palate surgeries with good effect. Actually,
okay,
there were two cases where intubation was not possible previously by some other anesthetist, and the cases were Pierre-Robin syndrome, and they brought to us in our OT. So I just gave Dexcat and then CO induction, and on spontaneous ventilation, my resident did the intubation actually with Tascope, that video laryngoscope. I have that video on Facebook actually long back. So it is very useful in difficult airway situations. You can take as much of time you need to intubate with
yeah,
spontaneous ventilation. And after securing everything, then only we give the relaxant to the patient.
yes, yes. This is very miraculous drug. Mm,
Yes, it
you
is
are
very
mentioning.
useful in such situations and for foreign body removals and all various types of scopies. I think there are a few questions.
Yes, sir. One question I don't feel it's sir. If ketamine is not available, what doses of propofol and dexmed can we use?
Dexmed, these both drugs are not, strong analgesics. They don't complement each other. They can cause bradycardia, hypotension. Both of them can cause. So it's better not to use them together.
Yes,
Whenever
yes.
I do use Dexmed as a bolus for major surgeries, then I use ketofol as an induction agent to avoid the side effects of Dexmed.
Propofol, yes.
When I don't mix Dexmed with ketamine, then I mix ketamine with propofol for better effect. So that the side effects of these two drugs together, they can cause precipitous hypotension and bradycardia. So better not to use these two drugs together.
From our Kishore is asking, sir, how to manage hypotension post procedure after Dexmed?
Dexcat usually don't cause any hemodynamic fluctuations. These are very well maintained. On the contrary, patient can have some hypertension because of the, it depends on what combination you are taking these drugs. If the patient has initial hypertension, you can take more of Dexmed and less of ketamine. If the patient already has some tachycardia, then you take more of Dexmed, less of ketamine. So accordingly, you can choose your combinations.
So in
Not better.
Dexmed, you use, sir, you use any premedication like atropine, glyco before
No,
doing that?
not needed.
Okay.
Unless it is a intraoral surgery or something like that, I don't use pyrolate because Dexmed
So
has a nice drying effect.
okay. So in pediatric patients, when you using Dexmed for UGI or
No,
even
no,
for
not needed.
procedural sedation, you don't use atropine as routine procedure point of view.
No, not needed. Dex
Even
has a
even
very nice drying effect.
even midazolam also you are excluding
No, no,
in your
not to
list.
be used. Otherwise, patient can have some extra sedation and there can be airway collapse, and you may need to supplement with some oxygen and all. So to keep the airway patency, better not to use anything along with this. If at
And
all you need something, you use a little propofol, just sleeping doses of propofol.
okay. So next question from Srikant Jaiswal. He's very wonderful person, sir. He's working at Umarkhed, and
Today only I had an opportunity to talk with him.
he's asking what is the incidence of laryngospasm after performing any painful procedures like induction of regional anesthesia and performance of surgical procedure with Dexcate.
Incidence of laryngospasm and
Yeah.
the airway issues are almost nil after Dexcate. This is the, greatest advantage of this Dexcate. The airway patency and tone is very well maintained. You don't need to handle the airway at all. And in painful procedures, either you use local anesthesia along with this combination, either you give a regional block or something. For painful procedures, you can even use little propofol.
For laryngospasm point of view.
Laryngospasm, I haven't seen till date with this combination. Even in patients with upper respiratory infection, I have given many cases where there was upper respiratory infections in COVID also. I am using this combination not only in kids, but in all sort of patients. The more morbid the patient is, more useful this combination is. I have used this combination in patients with CRF and all, 8 create as a procedural sedation, and then use either local or regional blocks. The patients
please sir, please.
The patients usually recover very well. There is no post-op nausea, vomiting. Patient can go home within 2 hours. Like small procedures like sebaceous cyst and all, I just give Dexcate and local infiltration. So patients are very happy. There is no pain, no post-op nausea, vomiting. Able to take oral within half an hour. They can go home within 2 hours. All daycare procedures under Dexcate.
I use once Dexcate. You mentioned about our topic last week or 2-3 weeks back. We discussed on that, and I did a use of Dexcate in a congenital head patient with the LA that surgeon used to do with the LA. So I given Dexcate, and it's very wonderful drug.
Yes, nothing is required actually. No oxygen, nothing.
Actually,
just
before
sleep
that,
like natural sleep.
Yes, before that I used to give atropine, midas, ketamine, propofol like that. But when I used Dexcate, patient was really out of sleep. I'm asked what is your name, and he's very peacefully answered my questions. I'm really appreciate, sir.
Just like natural sleep, they sleep for a while, kids, but nothing else. They don't usually have post-op nausea, vomiting, or anything else, unless the patient has something else which can cause nausea, vomiting. But with Dexcate alone, it is not there.
Post-procedure or pre-procedure agitation was abolished by Dexcate. It's really
in extremes of ages, it is very useful. Especially in extremes of ages, and more morbid the patient is, more comorbidities the patient has, it is especially useful.
Out of this topic, I want to ask, sir, are you using this combination in adults also?
Yeah, that's what I told you. I'm using this for all my daycare procedures, like small fibroadenoma, sebaceous cyst removal. For other painful procedures, I use generous propofol also along with Dexcate. Like
in adults also?
In adults.
Okay. For MPP procedure also, you using this drug nowadays?
For which?
For DNC, MPP procedures.
Depends. I actually use it for old patients for only DNC. For primary gravida or some MTPs,
6 and 8 weeks
dilatation, then I use either fentanyl or protein midas, because there you need some strong stimuluses there with dilatation. Or if I use Dexcate, then I use generous propofol. Around 100 grams of propofol along with this combination.
Okay. So in old ages, it's work for DNC.
Yeah, only in morbid obese patients.
Yes.
And in morbid ill patients, only Dexcate is sufficient. You don't need anything else, not even propofol. The
Perhaps in
only
our
thing
practice,
is if you use some extra amount of ketamine, then patients, especially younger female patients, can
yes.
have that delirium and psychological this thing. Then you can use propofol.
Okay. So we come across a lot of time that table surgeon came with 80 plus 90 plus ages and that patient for PV bleeding, and they are asking for DNC, and that time I'm really what I can say concern about that sedation part of, and if you are
Just
answered that
use
question.
Dexcate. That
Yes,
too
yes,
just
yes.
20-25 mcg of Dex and 50 milligrams of ketamine mixed together and just titrate to effect. That's all.
With 5 ml syringe,
Yes, with
slowly,
5
till
ml syringe.
2 minutes.
That's all. Patient don't need anything else. And they
That's
are
the
able
one.
to
सचिन,
take oral within half an hour.
हा सर प्लीज प्लीज.
आणखी क्वेश्चन आहे चॅट बॉक्स मध्ये.
ह्या सर मी तेच क्वेश्चन घेत सरांशी टॉक करतोय, कारण माझेही क्वेश्चन्स काही आहेत, कारण मी मलाही क्वेश्चन विचारायचे तर
तुझ्या
सोबत
गप्पामध्ये ते राहून जाऊ नयेत.
नाही सर, नाही नक्की नाही, कारण सर हे एवढे वॉन्टेड पर्सन आहेत, आपल्याला नाही मिळणार नंतर. I can talk him on phone also. It's not problem, but this is recorded version, so it is recorded in our YouTube channel also. So anybody can hear after that also. So I am asking all questions a lot with this. So next question I will take with our President sir's permission. Sir, can we do bronchoscopy under Dexmed?
Yes.
From Dr. Sunil Dikshit is asking.
नाही सचिन, त्याच्या आधी आहे ना डेक्समेड ऑब्स्क्युअर यूज ऑफ पायरुलेट. कुलकर्णी सरांचं क्वेश्चन आहे.
नाही सर, तो नंतर आहे. आता आपण ऑलरेडी वर आहेत. ऍक्च्युली मी श्रीकांत जयस्वाल जे आहेत उमरखेडचे आपले, त्यांच्या नंतरचा क्वेश्चन घेतोय ऍक्च्युली.
Yes, in bronchoscopy it can be used. Just like you have to prepare the airway with either nebulization or 10% spray, and you can use Dexmed as a sedation. If you are not intubating the patient, then you can very well use this combination.
So it's like 1:2 ratio for bronchoscopy.
Yes,
also.
1:2 is the ideal ratio what I use, but you can change the ratio according to your patient. Suppose your patient is a hypertensive one, then you can take more of Dexmed and less of ketamine. Suppose your patient has a hypotension, then less of Dexmed and more of ketamine. So you can alter your permutation combinations according to your need.
So I think the next question will it's from Dr. Sandeep Jadhav. What premedication you give prior to use Dexmed combination? Already we discussed. I think
not required.
Not
required any premedication.
Sir is asking our senior SB sir. We generally mention him SB sir. He is a Sudhir Kulkarni sir. He is asking, does use of Dexmed obscure the use of pyrolate? That also I think you covered.
Yes, generally the Dex has a very nice drying effect, and ketamine in limited doses does not increase the salivation much. If you increase the dose of ketamine very much, then only you can have such issues of increased salivation and increased secretions and laryngospasm, etc. But with this much dose of the ketamine with Dexmed, it generally don't cause any increased salivation.
From Prasuna madam, she's our Nanded branch junior person. She is asking, sir, can we use in bronchoscopy patient had already having lung infection and cough?
For all airway procedures, even for difficult intubation procedures, when you're trying this fiber optic intubation or some other intubations, like even for blind nasal intubations, we at times give Dexmed to the patient just to alleviate his anxiety and all.
So
that maintains the tone and integrity of the airways. There is no such issues. The airway can, even in morbid obese patients, it still maintains the tone of airways. So no need to actually secure the airway in hurry with this combination. Such things can happen when you use midazolam, propofol, or even fentanyl in excess doses. The airway can get collapsed and you need to ventilate the patient. But nothing such happens with Dexket alone. If you use propofol along with that or midas, then can happen. But with Dexket alone, no such issue is there.
So generally, I want to ask, in neonate or pediatric patients, you are using Dexket and patient is having active URTI, and still maybe you miss that thing and you give hydrocod, all these things, but still there is coughing in intra-procedure, like for congenital hernias or circumcision. That time, what you use generally?
Actually, with I have used Dexket in patients with upper respiratory infections also for short procedures like you said, circumcision, hernia, or below umbilical procedures. So generally used with either caudal or spinal or penile block for circumcisions. So usually just hold the airway and don't intervene much. Usually subsides even if the patient coughs. If you try and give some propofol or try to intervene the airway, handle the airway, then can create some problems. But just wait and watch. Usually nothing happens. Just
Give
hold the
hydrocod
airway.
or
Whatever extra secretions, you can suck it gently. If at all they are.
any part of nebulization like that.
If there is a spasm or something like that, then you can use other things like bronchodilators, nebulization.
Routine cough, you don't use nebulization.
No need. Don't stimulate the airway.
Okay.
Just be like that only. The patient is coughing means he's conscious. So just hold the airway, just give support. Don't handle the airway unnecessarily.
Sir, you from Dr. Kishore Manurkar, sir, have you ever used antidote of Dexmed if accidentally given more drug?
It's not available actually, atimemazole, and still it is in animal trials. I don't know it is available anywhere. I never got access to that drug. Atimemazole is a antagonist of this Dexmed, anti-sedan. I think it's
Is
market name.
it freely available at your place?
I haven't seen. I don't know. What I have read is it is still in animal trials they have done. If it is available or not, I don't know.
So this thing happen with you? You need antidote like that?
No, nothing.
So that concern with Kishore.
Usually after the initial bolus, most of the
Yeah.
times nothing is needed. If you use some regional block or something, the child is mostly sedated for almost half an hour or during the complete procedure. If at all you need just short boluses of the same mixture. If the child gets up, then the child sleeps again for another half an hour or 1 hour.
So this
So
combination
usually not needed if your block is perfect.
This combination is for almost for 60 minutes. It will work nicely. Dexket.
Depends on the anxiety level of the kid, activities, and the age of the kid.
Sir, you are using Dexmed in segmental spinal also, I think.
Yeah, for more prolonged action, I use intrathecal Dexmed, or along with segmental spinal. Most of the times when during laparoscopy sedation needed, I use Dexket.
Dexket with Dexmed in intrathecal purpose also.
Dexmed intrathecally for when I need some prolonged effects. As Dexmed can prolong the effect of spinal almost up to 3 to 5 hours with the same dose.
Dexket IV.
Dexket intrathecal along with IV has this, what you call is analgesic sparing effects, opioid sparing effects for almost
Yes.
24 hours if you use intravenously.
So you can you are using Dexcate in intrathecal.
I don't use the combination together in intrathecally.
Only
I use
Dex.
it intravenously.
Okay.
I use only
Dexmed
one,
is
either ketamine
Dexmed.
or Dex. Intrathecally, I don't use these combinations. I mean, this can be used, but I don't use more than one.
You use Dexmed in intrathecally,
Yes.
in segmental also.
Yes, yes.
That
When I need
combination,
a longer duration of effect.
it works almost 2-3 hours like that.
Yeah, more than, at times it takes around 4-5 hours also. When I used it for the first time, the patient was not moving his legs for almost 5 hours. I was a little bit worried. So then I started using less of Dexmed.
Nowadays, your
I use 10
dose
mcg.
for intrathecal segmental spinal, how much you use
It depends on
for
the procedure actually. Just rinse
for a
the syringe,
cholecystectomy, open cholecystectomy or lap cholecystectomy? How much you
just
use?
rinse the syringe with Dexmed. That is around 2 to 3 micrograms.
It's like
I
flushing of
calculated
syringe.
that. Just flush it,
Okay.
2 ml syringe.
Okay, sir.
Sorry. And then if you want to have an accurate calculation, you can use that BCG syringe for accurate calculation. Maximum dose I used is 10 micrograms.
So one my personal query is that I'm giving nowadays levoanamine in segmental spinal at level T L1 to T10 in between. When procedure is below T6, I used to give around L1 to T12 or T12 to T11, not above that. And sometimes it is sparing effects at sacrum levels. What to do? Means at that time, what should I do?
It depends for what procedure you are doing it. I mean, if you are giving adequate dose, suppose 2 ml at that level you have mentioned, T10 to L1.
Yes.
That much dose, 2 ml is sufficient for around 60 to 80 minutes.
Yes.
Even for sacral levels. If the procedure goes beyond this time, then the effect starts receding from sacral roots and patient can have discomfort during pelvic manipulations.
No, sir. From starting to in between also, sacral sparing is showing. And I used to give neck pain.
This problem is with isobaric drugs. They take little time for onset at the sacral level. I mean, after 10 minutes, the effect is perfect at sacral roots.
I use
this much dose. If your dose is very less, then there is sacral sparing for the whole time.
Because I use it actually. I use in above umbilicus procedures most of the time. That nephrectomy or stagon calculus or cholecystectomy or like that. But I use it in even hysterectomy, abdominal hysterectomy also. I give.
You can use a combination of 2 drugs. You can use a little hyperbaric initially, 0.5 ml, and then around 1.5 to 2 ml of isobaric. In different
I
syringes.
used to give levoanamine heavy 2 ml in these patients, and two cases I observed sacral sparing was there, and sometimes
with the heavy, there should not be any sacral sparing. Either you
2 cases
lost some
I
drug during
observed.
injection. You must have lost some drug during injection, or the needle got displaced.
Okay. Because
with
overall relaxation was good. Surgeon
no
was happy with this procedure, what I gave. But whenever pulling is there, that time patient was complaining about.
No, that is you must have lost some drug during injection, or some needle might have got displaced during injection, something like that. Dose is inadequate. With hyperbaric, no such sparing usually occurs.
So with 0.5 ml levoanamine heavy and isobaric 1.5 ml mixing of
1.5 to 2 ml depending on the duration you want.
For females, you mentioned in one of your recordings in TAS. I am recorded almost. I heard all your videos. That in that you mentioned about levoanamine heavy. You started in giving segmental spinal. I'm doing that only. Only 2 cases I observed that.
Levoanamine heavy I'm not using much, but ropivacaine heavy I am using for all my LSCS cases. Almost
With
more than
segmental
150.
spinal.
Not segmental, it is almost routine lumbar spinal. For heavy, I usually use routine lumbar levels. Unless it is an open procedure and you want higher levels like open cholecystectomy with a very limited dose of hyperbaric, then I use higher spaces, just 1 to 1.5 ml of the hyperbaric drug at higher levels in right lateral position for open cholecystectomy. That depends on the patient procedure.
So nowadays you are using ropivacaine isobaric drug for segmental spinal.
Pardon?
Nowadays you are using ropivacaine for segmental spinal.
If levobupivacaine is not available, I use isobaric ropivacaine or chlorprocaine if the procedure is very short. Chlorprocaine is also very good drug.
Yes, I use, but not in segmental.
40 to 60. Yes, you can use it for laparoscopic tubectomies, laparoscopic this short diagnostic laparoscopies.
In segmental
40 to 45 minutes. Yes.
Okay,
around 2.5
ropivacaine I
ml.
never use, sir, because ropivacaine just introduced nowadays, and I hardly use one time, but there is no relaxation. Surgeon complaining a lot of in
there is little less relaxation.
Yeah. So levoanamine is very much comfortable with segmental point of view.
Okay,
I will take next question, sir. Yeah, I will take next question from Dr. Sandeep Jadhav asking role of urinary catheterization after spinal, especially below 10-year-old child.
Role of urinary catheterization of the spinal, especially below. Generally, what happens in kids, the effect wears off very rapidly as the CSF volume is almost double than the adult. So whatever drug you give, it wears off very fast. In adults, it is 2 ml per kg CSF volume. In kids, it is almost 4 ml per kg. So the effect is very short-lived, and they pass urine within 1 to 2 hours. I generally don't use any additives with these drugs in spinal, so the effect wears off very fast and don't need any urinary catheterizations.
Yeah.
For post-op analgesia, use some blocks along with this. Like for hernia surgeries, I use some additional local infiltration at the incision site or tab block or penile block for circumcisions if permitted. Generally not required. I mean, I don't remember anyway if it was required in pediatric patient catheterization.
Next question from SB sir. Again, what is contraindications to use of Dexmed? Can we give it in asthmatic patients?
Yes, it is very good for asthmatic patient. Almost no contraindications unless the patient is very anxious and the patient can have delirium emergence with ketamine. Even in that cases also you can use more of Dexmed and less of ketamine. But it is more useful in morbid ill cases. The more morbid ill the case is, more strong indication is for Dexmed.
So, what is the take-home message? Is no contraindication till now for Dexmed.
Yeah, you can use it according to situation. You can vary the components according to your need. Especially in patients with irritable respiratory tract, it is very useful because there is no airway issues with Dexmed.
Almost.
Any other questions?
I don't think any questions at present. Nothing question. There is a lot of appreciation from all members. A lot of emojis were also flagged.
Thank you for that.
So from Sunil Dixit from Chandrapur, thanks is mentioning. Even our Prasuna madam also mentioning thank you for this talk. Overall, all questions were answered till now. Nothing is left. Still, any question other than this topic? Like sir's next topic is, we know everyone. He is a pioneer of segmental spinal. So,
My
any question
next
on that
presentation
you
is
want to?
on 29th, 30th of October at Bangalore. Actually,
Okay, sir.
online presentation.
Okay, sir.
This is pre-TechOn conference, I think.
So please share with your that link or anything is available.
I
with
haven't
us
got any
on.
link for that. That is a 2 days online conference, and then there is physical one in
Okay.
November. This is online first, 29th, 30th October, and then 19th, 20th of November is physical one, workshop like.
So I think on that also, anybody wants to ask questions can please, because these stalwarts never come again and again with us to meet.
No, I am freely available 24/7.
Yeah,
actually,
but face-to-face meeting and that freely asking.
Nothing
If
like
you want to,
yeah,
but no, sir.
practicing at very.
You are the
I know
stalwarts,
what are the
and
limitations
you
there.
are our own member from ISA chapter Maharashtra. We can really ask you anything. As a it's a private
sure.
forum, sir. So I'm really what is my actually concern is, we are in Silver Jubilee year, ISA Nanded City branch, and I need one private forum that was not recorded till date in India, that we should ask our questions or anything to our seniors also, and any problems related to that. So I started this ISA YouTube channel also. So repeatedly, a person can hear repeatedly, and a lot of small things you are speaking in your talk, that was really I'm experienced till now. So I'm going through that phases, what will happen next, or what I experienced lot of time in my private practice, that is I'm sharing with all of you. So these people will learn through this. So I'm one of my small gratitude from ISCCT branch, that everybody will learn from you and all stalwarts of ISA Nanded or ISA
I am actually
Maharashtra.
very much amazed by your work, Sachin. Actually, I don't know how you manage such activities every week. It's very difficult. I am also ISA President Amravati, but it's very difficult to collect all people for meeting and all. And it's very difficult to arrange a monthly meeting even. And you are arranging it every week. That is really creditable.
So
I just can't imagine that. We are actually finding it very difficult to conduct every month even. So hats off to you. Actually, you are conducting every week. That's great.
So it's your what I can say, it's
It's okay that we come here only for an hour, but you are doing it every week, and that too very regularly. So just incredible.
Nothing, sir. It's because of you it's happening. Not like it's not mine.
Okay, but I am also
it's
finding it very difficult to
your
conduct
work.
every
You are
month
basically it's your work. You are freely available with all of us, and you are sharing your knowledge on this platform. That was the great thing, not mine, because I am just a mediator.
Arranging is also, every week. That too, it's really great work. And you need some dedication for that. It's not easy. I know. It's very difficult to.
It's our president and our branch. They are giving me moral support for everything.
No other branch is doing this regularly.
Yes. So academic committee also, they are suggesting to talk or topics
we
for
try
that.
It for every month even, but
I will doing next after October. I will doing this monthly session with MMC points. Basically, what happening is MMC points are not getting with this. So I like to, because of our private forum point of view, I'm thinking that most of the members coming for CME, but they don't get MMC points. We are going CME.
Our next meet on 16th of October is with
after
MMC
that
points. We have already applied for it.
Basically, our case meets are completed up to November actually, but from November I will do week without week. we'll do monthly case meets with 4 or 5 speakers and 1 hour or 2 hour, 3 hours case meets with MMC points. I tried
Yes.
a lot of for 1 hour credit for speaker, 0.5 for viewers with MMC. A lot of email and exchanges happen, but not possible till date. We'll do from November for all our members that they at least they get 12 points for next year, to every month 1 point or 2 points like that. So thank you, sir. A lot of what I can say gratitude from our ISA Nanded chapter, that you came on very short notice. Whenever I call you, you are very easily available.
I can always be there whenever you call me. Thank you.
Thank you, sir. So I will conclude. This is our Platinum Jubilee celebration and Silver Jubilee celebration year. So happy to share that next week we will be with Cath Lab in and out all on 13th with Dr. Lipika Madam. She will tell us a lot of things on Cath Labs. So meet on 13th September. Thank you, sir.
Okay, bye.